everybody. So we are going to talk about the methadone in two sessions. The first session is today. So we have
Sunil sir, I think we lost him because of some connectivity issue. We'll wait for a few moments.
So Dr. Theodore, he's a doctorate. He got his doctorate in pharmacy from the University of California, San Diego, and then he completed his PG1 in acute care pharmacy practice at Memorial Care Long Beach, and his PGR2 in palliative care and pain management from the University of Iowa College of Pharmacy. And he is currently working as an adjunct assistant professor at the University of Iowa College of Pharmacy, and is practicing as a clinical pharmacist in Los Angeles County Department of Mental Health. And he has visited Toronto Institute of Palliative Sciences, and he has been involved with us in when we were doing the methadone. When we started methadone, we were very much afraid to very much afraid how to prescribe and what all medication should be avoided, etc. So he was very helpful, and he knows the practice of methadone in India also. So welcome to you, and
thank you for the introduction, Dr. Sunil, and thank you everyone for joining. So with today's section, I'm hoping to go over methadone pharmacology, and as we go through methadone, we'll be splitting it into two sections. Today is focusing on the fundamentals and pharmacology aspects of monitoring and safety parameters. In the next session, we will be focusing on calculations and conversions, and also success stories with methadone. And I'm hoping after we complete these sessions, we'll be able to answer any questions or concerns that you have, and also make everyone much more comfortable with utilizing methadone, which is a great medication that can be used for pain. And let me share my screen. Okay. So for the learning objectives with today's lecture, like I mentioned before, we'll be describing the pharmacological properties of methadone, compare the benefits and risks of utilizing methadone for pain management, and then identify monitoring parameters for safe use of methadone, and then recognizing appropriate patients for the safe use of methadone. So for the indications of methadone, there are multiple uses of it. In the US, we also use methadone for opioid use disorders, but oftentimes we also use it in pain management. And with our discussion, we're focusing on its use in pain management, and oftentimes we typically use it in chronic around-the-clock pain, patients that have renal impairments, or pain that involves neuropathic components, or even patients that are showing tolerance with opioids and or hyperalgesia. When we talk about adverse effects, there's different concerns with methadone or adverse effects patients can see. These are common side effects that are seen in other opioids in terms of chronic and serious side effects that we need to monitor. So the common ones would be constipation, sedation, nausea, hypotension, and urinary retention. More long-term use can cause concerns for opioid-induced androgen deficiency or OPAD, immunosuppression, and osteoporosis. And the more serious ones that we are more concerned about are respiratory depression, possible serotonin syndrome, QT prolongation, which is unique with methadone, and also concerns of torsades. But as we will go through monitoring parameters and safety, as long as we practice cautiously and appropriately, we would be able to utilize methadone effectively and safely in our patients. So with pharmacology of methadone, it is an opioid, as we all know, but it's a synthetic one and it's unique in its receptor activity. So it also acts on opioid receptors on the mu delta and kappa, but what's very unique with it is its additional receptor activity, which is its NMDA antagonism, which adds to its utility on helping with neuropathic pain components, and also can help with reducing opioid tolerance. Additionally, it acts upon the norepinephrine reuptake inhibition and the serotonin reuptake inhibition. So it also acts almost like an SNRI, which also helps provide additional neuropathic pain benefits. And when we think about methadone and its chemical structure, it actually comes as an enantiomer, meaning that there are a S enantiomer and R enantiomer, and there are some differences on its activity. So the S methadone component actually has 3 times activity compared to the right one, with acting on the cardiac human ether-agogo-relay gene, or the hERG blockade, and that actually is the main component that leads to potential QT prolongation by blocking the delayed rectifying potassium channels, versus the R methadone has as much as 8 to 50 times the analgesic potency compared to its S enantiomer. For the pharmacokinetics of methadone, when we administer it, it does come in orally or something as that oral medication, which can be tablets or syrups. When we take it orally, its bioavailability is generally pretty good, where it's 80%, but this can vary between people anywhere from 36 to 100%. And when we administer it sublingually, it is 30%. But if you do administer it sublingually, because the percentage is low based off of the oral mucosa, it does eventually trickle down the throat. So people will generally be absorbing it PO. In instances that in different areas, they may have methadone available in intravenous formulations. Currently, they have it in the US, but I don't believe it's in India right now, but just for completeness sake, when we do conversions between oral and IV methadone, we typically always take a more conservative approach. So when we convert oral methadone to IV, we do a 1 to 0.5 conversion. And then if you have a patient that's on an IV to PO, then we do a 1 to 1.2. So we're generally always taking a more conservative approach. And that's primarily because of the absorption bioavailability and always taking a conservative approach. For the half-life, methadone is unique because it does have a biphasic distribution in plasma and tissue. And what I mean by that is because of its long half-life, which is on average around 22 hours, but it can range anywhere from 8 to 59 in the general population, or up to 120 hours in hepatic impairments. What makes it biphasic is when it is first absorbed in the gut, there is an initial peak in plasma concentration, but because of it being a very lipophilic medication, it is highly absorbed into tissue. So it causes this two compartmental model where it is easily absorbed into tissue, but there's also, once it is absorbed and distributed, there is a slow release between plasma and tissue, which causes that second phase, or the slow release back into the tissue for clearance or elimination, primarily through the liver. So that is what causes methadone to be able to have such a long half-life, even though it is an immediate release medication. And when we typically think about dosing methadone for the purposes of pain management or analgesia, it typically works best from studies we found after using repeated dosing, and it lasts anywhere from 8 to 12 hours. So that is why oftentimes you'll see methadone when used in pain, it's dosed every 8 or every 12 hours. In regards to the metabolism of methadone, it is extensively hepatically metabolized through the liver. Hence why, if we do have patients that have severe hepatic dysfunction, it isn't necessarily a contraindication, but it just means that we need to be cautious about it and maybe more conservative with the dosing, or more slow with dose adjustments, just because it is primarily processed through the liver. The main concern that we would maybe want to avoid is if there is unresolved biliary obstruction, because it is processed through the liver and excrete and released through the bile. In regards to enzyme metabolism or CYP metabolism, the main substrates that we look at is actually CYP2B6, 3A4, 2D6, and 2C19. And the more minor CYP enzymes that it's processed through is also CYP2C9 and 2C8. And the CYPs that are listed in green also have an additional variation between person and person, because these CYPs are generally prone to pharmacogenetic variations, meaning that depending on someone's genome, they may have a different tendency of gene expression of these CYP enzymes. So that can add another variability on how patients may process this. So this is just something to keep in mind. But generally speaking, with methadone, there are many drug interactions because it is dependent on many different CYP enzymes for metabolism. So this may impact your clinical decision-making when you're considering methadone and or dosing, especially when patients have a lot of different medications. So next, going into cardiac risk factors. Like we mentioned before, there is a concern of QT prolongation or torsades. And the way that we can help utilize methadone safely is being aware of what things we may want to look out for, or be more cautious about in regards to cardiac safety. So typically, when we look at our patients that may have risk factors, these can include having electrolyte abnormalities, patients that are over the age of 68, patients who are female or have a history of structural heart disease, or genetic predispositions for torsades, or having other additional medications that can prolong QTC, or if they have a history of syncope, or if they have completed an EKG in the past and had a QTC, a corrected QTC of over 450. So based off of studies, they found that these risk factors If patients have one risk factors, they may have an odds ratio of 3.2 for torsades, and patients that have 3 or more of these risk factors have a risk odds ratio of 9.19 of torsades. So other predictors of QTC prolongation can be heart failure, hypokalemia, hypocalcemia, taking other medications with known torsades risk, rheumatological diseases, malignancies, peptic ulcer disease, and then methadone use of over 45 milligrams per day. So how do we utilize methadone safely? So what we can do to help mitigate some of these risks is to monitor and follow up as it is aligned with goals of care and weighing in the potential risk factors. And I want to emphasize that we want to align these monitoring parameters with patients' goals of care. These monitoring parameters are not necessarily required, especially in patients that are that their priority is more towards comfort-focused care, and also that have minimal risk factors. So doing aggressive repeated labs all the time or ECG may not necessarily be appropriate depending on where the patient is at and what their goals of care is at. And oftentimes the best thing to do is discuss with patients openly to discuss the risks and benefits so that they're aware and have informed consent. So generally speaking, when we do want to consider methadone, we would generally recommend getting a baseline ECG and electrolytes. In particular, we're looking at potassium, magnesium, and calcium, which are the main electrolytes that can contribute to QTC prolongation or QT prolongation. Once starting on methadone, generally recommendations are to get an ECG 2 to 4 weeks after the initiation, or when reaching methadone doses of 30 to 40 milligrams per day, and also if we hit the threshold of 100 milligrams a day. Other repeat ECGs may be warranted if patients develop new risk factors or are showing signs and symptoms suggesting an arrhythmia. And that way we can follow up to monitor to see if there's concerns. In regards to monitoring for adverse effects and waiting sufficient time for making dose adjustments, this is dependent on the half-life of methadone. And so like we mentioned before, the half-life of methadone is around 22 hours on average. So typically steady state is considered 3 to 5 half-lives. So in the general population, for patients that have normal liver function and are not of advanced age, we would typically recommend to wait at least 5 to 7 days before making any dose adjustments and monitoring for adverse effects. In patients that do have advanced age or hepatic impairment, we know that it takes longer for them to process methadone, therefore their half-life would be longer. So we would recommend to wait at least 10 to 14 days before making dose adjustments. So for looking at the concerns with methadone and QT prolongation, there was a study done at MD Anderson, and it was a prospective study where they enrolled 100 cancer patients and monitored for ECG changes at baseline, 2 weeks, 4 weeks, and 8 weeks. And actually, when they did the baseline for the results, 28% of patients did have a prolonged QTC. The median methadone dose was 23 milligrams. At 2 weeks, 31 patients had prolonged QTC, and only 1 actually had a QTC of over 500 milliseconds. And they did not have any patients that had greater than a 25% increase in QTC from baseline. And they did not record any events of torsades or VFib. So in regards to this major concerns of methadone always causing QTC, that may not necessarily be the case. Some limitations of the study is that it did have significant dropout, but because of the risk of QTC, we don't want it to be a deterrent for you to utilize it based off of this study and also all of our accumulated experience with using methadone safely and effectively for pain management. Now going on to drug interactions. Like we mentioned before, there are a lot of potential medication interactions with methadone that we want to consider. Generally speaking, there's a few acronyms that I like to utilize to help us remember. So for inhibitors, a lot of things that can inhibit the enzymes that process methadone, meaning that it may slow down the body's ability to process or break down or metabolize methadone, are GPAC-MAN. So grapefruit, which is not grapes, but it's a different citrus fruit that can often cause CYP inhibition, protease inhibitors, azole antifungals, cyclosporin, cimetidine, ciscobostat, macrolides, amiodarone, dronedarone, and non-DHP calcium channel blockers may be medications that can cause this inhibition. Oftentimes in these cases, we would say if there's alternatives to utilize or if possible to avoid these medications, we would recommend it. But if not, we'll go through the next slides of what are some recommendations of how do we utilize methadone in these cases. And then for CYP inducers, which are medications that can cause or stimulate the body to increase expression of these enzymes, meaning that we may break methadone down and process it more fast. A good acronym is PS-QUARKs. So phenytoin, patients that are smoking, phenobarbital, oxcarbazepine, rifampin drugs, including rifampin, rifabutin, rifampicin, carbamazepine, and St. John's wort are things to note. So again, if possible to avoid these medications or use alternatives that don't cause as much interactions, use alternatives first when possible. But in the event that that is unavoidable, we do have some recommendations. So for CYP inhibitors, typically the peak effects of these medications will occur within 1 to 2 days versus inducers, which cause an uptick in our expression of these enzymes, take 1 to 2 weeks after starting. So the key things is for recommendations based off of the white paper consensus is if you're starting an inhibitor, which can decrease the breakdown of methadone, or if you are stopping an inducer, which will also decrease methadone metabolism, the recommendation is to empirically reduce methadone by 25 to 33% and monitor carefully. On the other aspect, if we have patients that are on methadone and we're stopping an inhibitor, which would increase methadone breakdown, or starting an inducer, which may increase methadone breakdown, we actually do not recommend to make dose adjustments because we always want to take a more conservative approach. So we would recommend to monitor carefully for any increased pain or potential withdrawal symptoms. And we can mitigate this by providing adequate breakthrough dosing or breakthrough medication or short-acting opioids to help supplement while the body adjusts to the changes in their medication regimen or metabolism of methadone. And then once we get to a good state, then we can make adjustments based on how their opioid use has been adjusted. So overall, when talking about appropriate candidates for methadone, we would consider methadone in patients that have moderate to severe pain or pain refractory to other opioids. If patients have significant renal impairment, needs for long-acting opioids, or if they have high opioid tolerance and poorly controlled opioid-induced adverse effects with other opioids, or if they have a true phenanthrene or morphine allergy. One thing I wanted to emphasize before that, I forgot to mention before, is methadone, like we mentioned before, is primarily processed with the liver, and there is not as much concerns with patients with renal impairment. So we often use methadone safely in patients that even have renal failure, but we would just be cautious and monitor. But we can safely use it in patients with renal failure. For instances where we may want to be more cautious with methadone use is patients that have structural heart disease, a QTC over 450 but under 500, severe chronic liver failure. And remember, when patients have liver impairment or failure, it is not a contraindication, but more of a flag for us to be more cautious with the use and dosing. We would also want to be cautious in patients that have non-adherence to therapies because of methadone's long half-life. If patients have some challenges with that, that may be some concern. Patients that have sleep apneas, whether that be central or obstructive, or if they have multiple non-modifiable drug interactions, or multiple non-modifiable torsades or QT prolongation risk factors. Patients that may be inappropriate for methadone use may be patients with a history of sudden death or congenital QT syndrome or QTC of over 500 without modifiable risk factors. And when I say modifiable versus non-modifiable, if someone has a prolonged QTC, but we find that their electrolytes are off, we can always correct things like that versus other predispositions. Patients who have poor cognitive function or lives alone without a reliable caregiver to assist with administration of medications, then that may not be appropriate. Or patients that are unable to obtain follow-up, if there's any active illicit substance use or misuse, such as stimulants like cocaine or methamphetamines, just because this can have additive cardiac risks. Patients that are primarily needing acute pain or having a pain crisis or acute pain management, methadone should be more so used in someone that has chronic pain since it has a long half-life, or patients that have acute liver failure. Okay, and then so I just wanted to open it up to questions now.
Thank you, Theo. I think you can unshare the screen so that we can see everybody. So you can ask your questions now. So we just covered only the pharmacology of methadone. We will, in the next session, we'll see how to convert from an opioid to methadone. Yeah. Dr. Sarthi asks, what is the onset of action of methadone and how long before pain control is achieved? Yeah.
That's a great question. Thank you for asking that. So with the onset of action with methadone, I would treat it as the time that it may take to absorb it. So patients may start to notice some benefits within 30 minutes or an hour, but typically methadone should be used for a long-acting pain. So even though there may be some onset because of its long half-life, it may take time to reach steady state. So it may take time for the body to reach a steady level where it's consistent versus a slow uptick. Once we hit that steady state, which is that 5 to 7 days in most people, that's when we would consider that the peak effect. And we know that's how much pain relief that they're going to be getting from methadone. And that's why we also make recommendations for waiting that long before we make those adjustments. And I think the next question was from Molly Thomas.
Yeah.
Can methadone be used as
Can
first line?
methadone be a first-line drug in any situation, or is it only when there is improper pain control?
So generally speaking, I wouldn't necessarily start a patient right on methadone because I would want to gauge how their pain is. And if they're appropriate for opioids, I would probably use medications like morphine first and see how much they use and how much they respond to gauge how much they use it. So if someone only has intermittent pain, maybe pain once a day or twice a day, and it's more flaring pain, then I may not necessarily jump to methadone first.
So I would like to add that when Theo presented, you might have seen that there are a few indications for methadone use, and one among them was patients with chronic kidney disease. So when we have a patient with elevated serum creatinine, in India we have only morphine to use in the step 3 ladder. Otherwise, you have to use fentanyl, but even fentanyl mainly it is used as a patch, and then pain control would not be possible with the fentanyl patch. So in such situation, maybe methadone may be used as a first line agent. And another situation, what he mentioned was true opioid allergy. So patients who are allergic to other opioids. So rarely some patients can be allergic to morphine. And in such situation, I will be able to use methadone as a first line agent. Okay, there is another question. And Dr. Savitri, what is the risk of dependence with methadone since it is recommended in the chronic pain and opioid use disorder?
So its risk with dependence for methadone, I would say, is similar to the use of opioids in general. And I think the way, if we're worried about opioid use disorders or dependence, is making sure that we are using opioids in general when we find that it is clinically appropriate. And as long as we are monitoring it safely and also monitoring its use appropriately with patients, right? So especially if patients have some issues with taking it consistently, then if they have a caregiver that can assist with it, and also controlling the amount that we're dispensing to patients. And that may vary depending on each patient's means of coming in or how far they may need to travel. But I wouldn't necessarily give them a 3-month supply of opioids, since that may increase some of that risk. And in regards to opioid use disorders, in the US, typically methadone is used to help with mitigating withdrawal and cravings. So because of its long half-life, we actually have methadone clinics where patients can come in every day to get once daily dosing to mitigate that. So they're not necessarily using it for pain. So they can get away with once a day dosing versus our typical 2 to 3 times a day.
Anybody else?
Good evening, Dr. Sunil.
Yeah.
And Dr. Theo, thank you for the presentation. I just wanted to ask, in neuropathic pain, there is no RCT to say that methadone is better in neuropathic pain. I mean, correct me if I'm wrong. That's what I've understood, that there's no randomized control trial. It's anecdotal evidence, isn't it? Because we are assuming, because it is an NMDA antagonist and norepinephrine and serotonin reuptake inhibitor, it is going to be better in patients who have neuropathic pain. So could you please elaborate on that, please? And the use of other adjuvants like amitriptyline or gabapentinoids along with methadone in the mitigation of neuropathic pain. Thank you.
So in regards to neuropathic pain and other adjuvants, I wouldn't necessarily say that it's different, but the main thing is when we compare methadone to other opioids, so opioids like morphine or oxycodone, we know that that it does have better control with pain. And there are some articles written and comparing and showing that there is efficacy with the neuropathic pain components compared to these other opioids. But if the priority is neuropathic pain, you can certainly use multiple agents to help with that. So if you need to add on like a gabapentinoid in addition to methadone to target neuropathic pain, that can be something to use. But again, there may be some patient variability in response. But if their main component of pain is neuropathic and we're just starting them up on a medication, then it may be appropriate to trial a different medication agent if you don't think that an opioid is necessarily warranted quite yet. But if the opioids are warranted and they're not responding to other adjuvant agents, then methadone can have a better role compared to other opioids for having that additional neuropathic pain component, but also that's additional benefit for patients that are on things like morphine or fentanyl or oxycodone, and they have a very high opioid requirements. It can also reduce the amount of overall opioids that they need.
Thank you. Can I ask one more question?
Yeah.
So in my center, I work in a cancer center. So often I use methadone when the patient has probably a neuropathic component and a very high dose of opioid requirement, that is primarily morphine. So the patient is already on adjuvants like tricyclics and gabapentinoids. So do you recommend that I continue the adjuvants as it is and add on methadone according to the conversion factor, or do I taper down the tricyclics because there is a element of QT prolongation cost by them as well?
Yeah. So generally speaking, I personally would recommend to come off of the tricyclics just because the main mechanism of action is primarily through the norepinephrine serotonin reuptake inhibitors to help with neuropathic pain components. And like you mentioned earlier, there's that additive risk of QT prolongation. So then we would be doing a duplicate receptor activities targeted, and also having additive risk of QT prolongation, and also additional risk of serotonin syndrome.
Thank you, Dr. Theo.
I think there are a few RCTs with methadone comparing with morphine and fentanyl. But I think one of the study was underpowered because they were not able to recruit many patients with morphine comparing with methadone. And another one, I think they compared methadone with fentanyl, and they found that it is better than fentanyl for treating neuropathic pain. And I also think there is one randomized controlled study from MNJ Cancer Institute on neuropathic pain. And I think they concluded the efficacy of treating neuropathic pain was not superior in comparison with the morphine. But as you told, so I think that we need to have more studies. But for the time being, what we understand is considering the NMDA receptor antagonism as well as tricyclic antidepressant action, it should be beneficial. And if you look at the literature, one of the indications is complicated treatment of complicated neuropathic pain.
Thank you, Dr. Sunil.
Anybody else? If so, some of the important points on methadone is when you look at methadone, please think that it has three beneficial effects. One is it acts on all opioid receptors, so mu, kappa, and delta. So the pain relief would be better compared to other opioids. Then it acts as a tricyclic antidepressant. So it would be beneficial in treating neuropathic pain. It is also an NMDA antagonist, but I have seen some papers describing the NMDA receptor antagonistic activity as equivalent to that of ketamine. But there are some other papers which says it is less, it is much inferior to ketamine. But there are enough evidence to say that it has useful NMDA antagonistic activity. If you look at the literature, and there are so many patients who are on thousands of milligrams of oral morphine equivalents, and some patients are on 1000 milligram, 2000 milligram, 5000, 8000, 12,000. And when these patients were all started on 30 milligram of methadone, they had very good pain relief. So all of them started on 10 milligram of methadone, that is total 30 milligram per day, and they had very good pain relief. So what they were telling us, NMDA receptors is involved in opioid tolerance. So methadone can prevent and reverse tolerance. So that is one of the clinical significance of methadone. So these are the three beneficial effects of methadone. But one of the disadvantage or the most feared side effect is QT interval prolongation, tau study points, which leads to ventricular arrhythmias and death. But it is said that even Theo has shown you a study from MD Anderson Cancer Center, which says when you use methadone at lower doses, maybe less than 40 milligram per day, the chance of producing tausites and ventricular arrhythmia is very, very less. And another important point I think he brought out was methadone takes about 5 to 7 days for the blood level to destabilize. But in case of morphine, it takes only 24 to 36 hours. But methadone takes about 5 to 7 days. So this is the main difference when you start a patient on methadone. So you have to be very patient until 5 to 7 days before increasing the dose of methadone. And in case of patients who has severe liver failure or patients who are elderly, even it may take a long time, up to 10 to 14 days. So in elderly people and patients with liver failure, it is better to start with a lower dose and wait for some more days. And another important is the main metabolism takes place in liver with the cytochrome P enzymes, and you know that there are many cytochrome P enzymes are involved in the metabolism of methadone. So we also know that there are many medications which we use in palliative care. They also metabolize in liver. It may be an inhibitor or it may be an enzyme inducer. So we have to be careful what medications are the patient taking, and according to the medication, we have to adjust the dose of methadone also. So Theo give you some methadone, which is very useful. So there are many medications which can either inhibit or induce cytochrome P enzymes, which would be impossible for us to remember. But the strongest one are what Theo has told you. So it is important for us to remember those medications. Yeah. Yeah, I think those are some important points that Theo covered in this session. And okay, while patient is on methadone, how do we decide upon breakthrough dose with morphine? Yeah.
So typically when we have patients, and we'll go over this a little bit more in the next session, but typically when we start patients on methadone, oftentimes they may already be on some opioids, and then we would do a conversion on what their opioid requirements are, and then converting them into a regimen that will provide them with around the clock, around the day coverage with methadone for pain. And then we would continue them on or make a breakthrough dosing for morphine. Typically, the recommendation is 10 to 15% of their daily opioid requirements as breakthrough dosing every 3 to 4 hours, or SOS dosing.
Dr. Meenakshi, anything else?
Sorry, thank you. Yeah, I got that. So So when you say 10% of the thing, are you meaning that we just continue with the breakthrough dose of methadone, or whatever dose that we converted them on methadone, we use the 10% of that morphine dose as breakthrough? I'm confused. Sorry.
Right, sorry. So let me clarify. So I'll go into this a lot more detailed with practice calculations at our next session. But an example would be, say, if we have a patient that's utilizing SOS dosing of morphine, and when we do a calculation, they're actually using around 100 OMEs a day, or oral morphine equivalents. When we do that conversion, which we'll go over at the next session, whether that be a 10-to-1 or 20-to-1 conversion, and we give them the Q8 every 8 or every 12-hour dosing for methadone, the 10% of their daily opioid requirements was 100. So we would recommend that you can give breakthrough dosing of morphine of around 10 milligrams every 3 to 4 hours that they can utilize while we wait for the methadone to reach its steady state or peak efficacy, and then continue to see how their opioid requirements are with breakthrough dosing, and then make further adjustments or titrations.
Okay, so
Got
I
it.
would like to comment here because in US they use 1/10 as breakthrough dose. If the patient is on 100 milligram of or 90 milligram of morphine, they use 9 milligram as breakthrough dose. But if you calculate, that will be 15 milligram Q4 hourly and SOS dose. But here in India, we use the same regular dose as the SOS dose, the breakthrough dose. That is 15 milligram.
Got it, Dr. Sunil. Thank you.
Theo, there is another question: is methadone safe in children?
Yes, so methadone is safe to use in children as long as you're using the appropriate dosing and monitoring in children, and then also keeping in mind the risk factors that we talked about before. So in children, if there's any structural heart disease that we're aware of, or if they have congenital QTC prolongation, or maybe history of sudden death in the family, then we may be more cautious or adverse to it. But methadone can definitely be used in children safely as long as we're monitoring.
Okay, I think we will move on to the patient story, which will be presented by Theo, and after that, if the time permits, we will do something. Yeah, Theo, it's over to you.
Thank you. So with today's case presentation, we have a 57-year-old male who has a diagnosis of stage 4 pancreatic cancer with metastases to the spine and liver. They also have common history or medical history of hypertension, type 2 diabetes, and CKD. And chief complaint, they present to an outpatient palliative care clinic with concerns of uncontrolled pain to his back and his legs. History of illness, he was diagnosed with pancreatic cancer 1 year ago. Pain was previously well managed with ibuprofen, paracetamol, and a few doses of morphine. However, the disease has progressed with lesions in the liver. Back pain has progressively become worse. He did take additional ibuprofen because of this, but that caused AKI. And then now they found new lesions in the spine on X-ray and MRI, and he just completed palliative radiation to the spinal metastases. For examination for labs 1 month ago, he did have a serum creatinine at 2.4. Based on calculations, there's an estimate creatinine clearance 25 milliliters per minute. Sodium is 138, potassium 3.2, fluoride 98, CO2 22, BUN 50, glucose 170, AST 84, ALT 74, T-Billy 0.4, alk-phos 180, albumin 3. Vitals are within normal limits. Bowel movement, patient describes as normal, but when we asked when the last bowel movement was, it was 5 days ago. On MRI, there's extensive osseous metastases throughout the spine, pathological compression fractures of L1 and L3, no spinal cord compressions, metastatic lesions throughout the sacroiliac bones. On physical examination, no acute distress. He had mild temporal atrophy. Cardiac had normal rate and rhythm. Clear auscultation. For GI, there's faint bowel sounds. Extremities, mild edema, no lesions on his feet, and neuro was intact, no signs or concerns of myoclonus. For treatment and significant investigations, he was initially diagnosed in June 2020. Lesions were considered inoperable. CT he completed 8 cycles of FOLFIRINOX for chemotherapy and completed 6 cycles of paclitaxel and gemcitabine. And for radiation, he received 24 grays over 3 fractions for palliative radiation. And then for analgesic history, the patient did try gabapentin, but did not really know any pain relief, and has tried doses as high as 1,800 milligrams in divided doses per day, but just noted it only caused sedation. He did try ibuprofen in the past, had mild relief, but was told to stop because of his kidney function. He did try amitriptyline in the past. It did help pain, but the patient could not tolerate the side effects, which he had dry mouth and mild confusion. Patient did complete a 5-day burst of dexamethasone last week with minimal relief, and patient cannot afford to utilize a fentanyl patch. On pain assessment, patient's back pain describes it as constant pain with flares. The quality is described as sharp, burning, achy, with radiation shooting down his legs. The severity is as high as 8 out of 10. The lowest it's ever gone with medications was a 5 out of 10. For palliating factors, he says the only thing that helps is laying on his side and using morphine. Things that aggravate his pain is sitting and walking, and this has impacted his function with being able to walk and sit, and limits his ability to do things around the house. He's unemployed and also has poor sleep. For leg pain, he describes the pain as continuous, with pins and needles and numbness, and it feels like sandpaper with touch. There's no radiation. Severity is 2 out of 10, and at the worst, it's a 5. Nothing helps with this pain. Aggravating factors are any touch or abrasion, and then difficulty with walking and poor sleep is impact of this function. For psychosocial aspects for this patient, he's currently widowed. He had 2 children. One died of labor complications, and he has 1 son. He currently lives with his son, who provides some support and helps with his medications. The patient did previously work as a carpenter, but is currently no longer able to work. For his current medications, he's on hydrochlorothiazide, 25 milligrams. And he's also taking insulin, 5 units before meals, and insulin and pH, 10 units twice a day. And then he's also on ciprofloxacin, 500 milligrams daily, and he started 2 days ago for suspected UTI. And he's on omeprazole, 20 milligrams twice a day, paracetamol 500 Q4 SOS dosing, and he's using on average 5 doses a day. And for morphine, he has morphine 60 milligrams PO Q4 SOS, and he reports that he's using 6 doses a day, and sometimes he's taking as much as 7 when the pain is very bad. So right now, his main concern is uncontrolled pain and financial distress. What are some interventions you might consider?
Yeah, I think anybody can try to answer this question. So the patient is on 60 milligram of morphine for hourly, and he complains of low back pain with the pain score is 8/10, which decreases to 5/10 occasionally. And in addition, sorry, he has bilateral radiating pain on both lower limbs, which is mostly 2/10 and increases to 5/10. Yeah, I think interventions, I mean, Theo meant what can be done.
Yeah, so from this patient on their presentation, there are concerns of uncontrolled pain. That's around the clock pain and also intermittent flares. There's neuropathic components since he's describing the shooting, pins and needles. And also the other thing to key in on is he mentions that any touch feels like sandpaper, and any abrasions cause pain as well. So that may also key us in on maybe he may be having hyperalgesia.
So there are a few responses. One is why not dexamethasone, and the other one is epidural catheter, epidural analgesia. Then celiac plexus block, biphosphonates, duloxetine.
Great. So the patient did already do dexamethasone first to help with the inflammatory components, but the patient's still having pain. For celiac plexus block, generally speaking, we would think of it more of abdominal pains, but if the patient was presenting with pains in the right quadrant, or if it's radiating to the back, if we think that the liver metastases are causing that, that could be a consideration. But I don't think that would necessarily help with the back pain due to the lesions in the spine or the leg pain. But I think if we think that the lesions in the liver is adding to a component to pain, then that may be a good consideration. Let's see. And yes, so if he is having neuropathic pain, we would want to consider medications that can help with that. And for an epidural block, that could be a consideration, but because of the diffuseness of it, that may cause some difficulties with that. And Manasi said bisphosphonates, and I think that's a great consideration, right? Because there are bone metastases, we often look to that to help with pain. And then also duloxetine, that could help with pain. So let's kind of go through some of these other options, right? So I think bisphosphonates would be a good idea. However, the patient does have CKD and their creatinine clearance was 25. So it's actually contraindicated in this patient. And also because of the patient's renal function, duloxetine is also contraindicated. If they had renal function, I definitely agree and would consider these agents. So for this patient, there's no current regional or sympathetic blocks that could be considered right now because the patient actually has an active infection, so we're concerned of infection risk. And for neuropathic agents, the patient couldn't tolerate TCAs in the past. And also, in this case, if we're considering methadone, I wouldn't recommend to do both. The patient couldn't tolerate NSAIDs, especially because of the renal function, and they had AKI in the past from it. And then his oral morphine equivalence requirements are high enough where we wouldn't recommend other agents such as buprenorphine because it may precipitate withdrawal. And like dexamethasone, we mentioned he did already get a burst of steroids with minimal relief. And then Savitri mentioned methadone or ketamine. So yes, I would definitely consider methadone. If possible, you could consider ketamine, but in regards to availabilities, sometimes that's difficult, especially if we're primarily trying to utilize it in the outpatient setting. But in this case, I think methadone would be a great and appropriate choice. So what additional tests may you want before starting methadone?
So before you start the patient on methadone, what all would you do? What all investigations?
And just as a brief review, these are the labs that we currently have.
The ECG and electrolytes. There are some responses.
Okay.
ECG,
So
electrolytes, family history.
Perfect. And then just to specify, which specific electrolytes do we want?
Yeah, potassium, calcium, and magnesium.
Great. Okay. So for additional monitoring, we wanted ECG. So that's done. And the QTC came back as 463 milliseconds. We did a magnesium and a calcium. And the magnesium was 2 and calcium was 8.6. So those were within normal limits. We did already have a potassium, but I think a repeat would be warranted since their last potassium was low, and they do have a slight prolonged QTC. So we did a repeat on that, and it was 3.2. And it would also be reasonable to get an additional LFT if we are worried about substantial change, or if there's any signs that are showing us major change in liver function. But in this case, it was on the labs were a month ago and we didn't find major changes. So it may not necessarily be necessary to do a repeat because we already had a baseline LFT that was relatively recent. So in general, with this patient, this was a 57-year-old patient with metastatic pancreatic cancer with multiple lesions in spine. He did complete chemotherapy and palliative radiation. There was components of mixed nociceptive and neuropathic pain. He required frequent and high doses of oral morphine. Other first-line adjuvant agents were contraindicated or didn't help. And then there is some concerns of development of tolerance and hyperalgesia with the opioids for this patient. So for the main points that we talked about with this case, methadone may be a good option for neuropathic pain, hyperalgesia, tolerance, long-acting analgesia, and patients with poor renal function. And in this case, he has CKD. When possible, we want to reduce drug interactions. So in this case, he had a UTI and they placed him on Cipro. So if there's other alternative agents we can utilize, so for example, we could try to do Keflex instead of Cipro to treat the UTI, which would be indicated and help minimize drug interactions. For the other medication he was on, the omeprazole, we can consider using H2RAs instead of the PPI because of the drug interaction with CYP2C19. Getting baseline and routine labs. So the electrolytes that we're looking at is potassium, magnesium, and calcium, LFTs, and an ECG. But again, remember that the ECG monitoring is based off of patients' goals of therapy and discussing benefits and risks with patients to get an informed consent. And then when possible, correcting reversible causes of QTc prolongation. So some of these risks in this case were the patient was also taking Cipro that can cause QTc prolongation. So if we also switch to an alternative antibiotic that can be treating the UTI, we would also be helping mitigate that QTc risk prolongation. For our palliative patients, also checking if there's opportunities to deprescribe. So is a patient still needing these antihypertensives? So in this case, since they had a relatively normal blood pressure, do they still need hydrochlorothiazide? Because this can impact patients' electrolytes too, based on the mechanism of action. If they do, then maybe we can consider adding on potassium supplementation to address this hypokalemia that can also contribute to QTc prolongation. And then again, making sure that if we do start methadone, not to adjust or titrate the dose until patients achieve steady state. So at least 5 to 7 days, and then 10 to 14 in hepatic dysfunction. And then don't forget to give patients bowel regimens to prevent constipation. So even though the patient said that their bowel movements have been normal, but further investigation, we find out that they said they're not having bowel movements for the last 5 days. That's more of a concern. So we may want to be more specific with patients. And in this case, we can consider starting a patient on Senna or considering giving suppositories or enemas, especially since it's been 5 days, which is typically a higher concern. If we are concerned for impaction, then the patient may need digital disimpaction to prevent further complications. And then so with today's discussion, like I mentioned before, it is focused on the monitoring parameters and considerations and the general pharmacology. And then we'll revisit this case to do the calculations and conversions. But I wanted to open it up to questions now.
Okay. So now I think what we will do is we have some questions which Sripriya will show you as a poll, and there are some 15 questions. So the questions will be the revision of this session. So she will launch the questions, and you can select the appropriate answer and submit it. So, so this will not be, you can select any answers, and this will not be, this evaluation is not going to use for any other purpose. So please feel free to do this. And second question, methadone can produce torsade points, especially in higher doses, which can lead to sudden death. That's true, isn't it? We know that when people use higher doses of methadone, and they are more prone to have torsade points, which can lead to the ventricular arrhythmias and death. Methadone has the following actions, except. So the first three, that is, it has agonistic action at opioid receptors. It is an NMDA antagonist. It also acts like tricyclic antidepressants. So the correct answer is prostaglandin inhibition. So methadone doesn't have prostaglandin inhibition. And the fourth one, the risk of torsade points starts at corrected QT interval of 50 milliseconds and is significant at 500 milliseconds. Yeah, we know that 500 milliseconds without any modifiable risk factors is a contraindication to start a patient on methadone, because then the risk is very high. So the answer is true. Methadone has an NMDA antagonistic activity that is equal to ketamine. So I think this question is somewhat controversial, because now I don't know the answer, because previously when I put this question, I thought I do know that answer, because I have a reference which says the NMDA activity of methadone is equal to ketamine. But now there are some new article has come which says it is not as equal to that of ketamine. So I think maybe the recent evidence might be the NMDA activity may not be equal to that of ketamine. So maybe false might be the answer. And methadone is mainly metabolized in liver. I think, yeah, all of you got it right. Which is correct regarding pain relief. Methadone and dextropropoxyphin are safe in chronic kidney disease. Methadone and codeine are safe in chronic kidney disease. Methadone and fentanyl are safe in chronic kidney disease. Morphine is the safest opioid in chronic kidney disease. So dextropropoxyphin is an opioid which we have used previously, but then there was temporary suspension. But now it has come back into the market, which was available as Prox1. So dextropropoxyphin is should not be used in patients with renal failure. Okay. Likewise, codeine also. And we know that methadone and fentanyl are two opioids which is supposed to be safe in chronic kidney disease. So the third one is the right answer. The oral bioavailability of methadone is 70 to 80%, which Theo already has mentioned. Okay, so there are, I think, 7 more questions. So Priya, you can now launch that questions. So the first question, methadone can be administered through the following routes. The answer is oral, rectal, sublingual, subcutaneous, and intravenous. And we need to understand that in India, we have only oral preparations. We don't have injections, but it is available outside India. And right now, we have only syrup. Previously, tablet was also available, but now we have only syrup. Next one is methadone blocks HERG related gene, that is human either a go related gene in myocardium and can lead to increased QT interval. That's right. This HERG related gene is present in smooth muscles. but it is abundant in myocardium. So when methadone is given, it blocks HRV related gene in the myocardium, and it increases the QT interval. The following medications can cause increase in QT interval if co-administered with methadone: azithromycin, ciprofloxacin, haloperidol, none of the above, all of the above. It is all of the above. So just understand that there are many medications that can cause interactions with methadone. So we usually use macrolide antibiotics like azithromycin, clarithromycin, erythromycin, etc. And fluoroquinolone is another group of drug which is being usually used: ciprofloxacin, levofloxacin, ofloxacin. Then SSRIs, acetopram, citalopram, all those medications. And antipsychotics like haloperidol. These all are medications which we usually use in palliative care settings. So we have to be careful while we prescribe methadone for patients when they are on these medications. Okay. Next one is methadone's blood level will be stabilized. So 5 to 14 days, isn't it? So we told that in patients who are healthy, they will take about 5 to 7 days, whereas patients who has liver failure or patients who are elderly, they may take up to 10 to 14 days. So the answer is 5 to 14 days. Medications that can decrease the methadone levels in blood are, that is dexamethasone. All the others can increase the blood level of methadone. Next one is methadone is easy to use just like morphine. No, we know that there are many things which we need to be careful. So it is not at all an easy medication to use just like morphine. Following are the indication to use methadone, except opioid toxicities as an adjunct, complicated neuropathic pain, safe analgesic in renal failure, allergic to other opioids, opioid-induced hyperalgesia or tolerance, well-controlled pain. So, which is an indication to use methadone? Following are the indication to use methadone, except. So, which is the right answer? Seventeen people has given the choices well-controlled pain. That's the majority. Okay, so I think this question maybe the answer may not be very evident. Even in patients, suppose a patient who has well-controlled pain with morphine, and the patients tell you that sorry, I am unable to take morphine every 4 hours. Can you do something else? So maybe methadone is a choice there, because you need to give only twice, isn't it? So there is even all the answers are we don't have the except answer here. So I think that's it. So all these conditions you can use methadone. Okay. So thank you. Uh, uh, if you have any more questions, I think we can take one more question if you have any. Okay, I don't see any more questions. So I think we will stop it for the day. So thank you, Theo, for the excellent session. And thank you all for your active participation. We'll see you next week with more methadone conversion session. So thank you all.
Thank you, sir.
Repriya, you are mute. Unable to hear you. No, still,
Audible now?
yeah, it's okay now.
Sorry for that. Extremely sorry for that. So this is Sri Priya along with Dr. Theodore and Dr. Sunilkumar signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.